Good afternoon, and thank you for joining our Utilization Management webinar on STEP therapy. I'm Courtney Yo-Savage, Senior Vice President of Policy and Advocacy at the Cancer Support Community. Before we begin, just a few housekeeping items. Today's webinar is being recorded and will be available for viewing afterwards. An email will be shared in the coming days with all of our registered attendees. If you have any technical or administrative difficulties, please let us know by using the chat box at the bottom of the screen, and we will do our best to address them. Please submit any questions via the Q&A box throughout the presentations, and we'll do our best to get to them during today's Q&A portion. This roundtable is part of Cancer Support Community's Forum on Utilization Management. Now in its 5th year, the forum was created to foster thoughtful discussions that engage a broad range of healthcare stakeholders and keep the focus on patients. Ask tough and nuanced questions about when various approaches are acceptable and when they have the potential to harm patient health outcomes, as well as identify new ideas and promising practices that optimize evidence-based healthcare. Strategies are common policies which, when implemented appropriately, can enhance patient experience and improve care quality. However, they can also negatively impact patients' access to care and contribute to provider burden. Since 2019, CSC has hosted quarterly roundtables on critical policies. I want to take a moment to thank our sponsors for helping us to facilitate this important dialogue. CSC is committed to fostering conversations that inform and engage all stakeholders in the creation and implementation of strategies that include the patient perspective and incentivize cost efficiency through improved patient care and outcomes. We are all here today because we believe that we have a role to play in making high-quality healthcare accessible. And so we extend a special thank you to Bristol Myers Squibb, GSK, Janssen, Novartis, and Sanofi. Before we introduce our panel, I want to take a moment to acknowledge CSC CEO Debbie Weir to share a few opening thoughts. Debbie?
Thanks so much, Courtney, and thank you everybody who's joining us today. We've been proud, and we are a proud leader in patient advocacy and assuring that patient voices and their experiences and their caregivers and loved ones are centered in all throughout oncology and beyond. As Courtney said, this is our 5th year that we are providing these roundtables, and they're extremely informative on issues that directly impact patients and the families that we serve. So I want to thank all of our guests today and all of our speakers. STEP therapy may be a topic that you're not as knowledgeable about, and maybe you are and you want to dig deeper into it. So that's what this purpose of these roundtables are. So I want to start with a couple of poll questions that we're going to have. And the first poll question is, which of the following best describes you as a participant in today's webinar? So perhaps you're a patient, caregiver, a CSC or Gildas Club network partner, social worker and care navigator, clinician, policy or advocacy staff of a stakeholder organization, pharmaceutical industry staff, or insurance payer industry staff. So please click the one that is applicable for you. Okay, and then our second poll question is, what do you hope, let's look at the results here. So 11% today are our network partner representatives. Thank you so much. You're serving patients on the ground throughout our 190 locations. Oh, and then also we have policy and advocacy staff, and then also pharmaceutical industry staff. So thank you so much. Each of you play a very important role in putting the best interest of patients first. Our second question is, what do you hope to get out of this session today? Understanding STEP therapy, learning what I can do if STEP therapy impacts my care or a loved one's care, getting an update on federal policy initiatives, or learning how I can help affect change at the state and federal level. So if you'll take a moment to click what is most relevant to you. Very good. And then the results of this question are, looks like getting an update on federal policy initiatives and then learning how I can help affect change at the state and federal level. So very policy advocacy focused. And I would say this is one of the reasons, again, that we lead the effort on these utilization management roundtables on a quarterly basis, because it really is these type of conversations plus research that informs cancer support communities, policy and advocacy priorities, and also working in all of the various coalitions. So thank you again for being with us today. And then I'll give it back to Courtney.
Thanks very much, Debbie. And it's great to see that we have so many subject matter experts participating in today's call. I think that means that we can have a really robust and thoughtful discussion and really dig into the weeds on this. So I'm looking forward to today's panel. So without further ado, allow me to introduce Sarah Buchanan. Sarah is Director of Federal Government Relations and Health Policy at the National Psoriasis Foundation. She's also co-chair of the Safe Step Act ad hoc coalition. In addition to advocating directly to federal policymakers within Congress and federal agencies, she also advocates directly with the private insurance sector and other allied stakeholders to improve policies and advance the health and wellness of the psoriatic disease community. Sarah is a 12-year health policy veteran with a passion for collaborating with patients, families, and providers on public policies to improve patient access to care. Elif Andac-Jones is co-lead of the research department here at Cancer Support Community, and she's a sociologist and methodologist by training. Prior to joining CSC in March of last year, Elif worked as a research consultant for a wide range of institutions, including NIH, the World Bank, and a number of nonprofits and NGOs in the United States, the Middle East, Europe, Central Asia, and North Africa. With a focus on mixed methods research and comparative analysis, integrating qualitative and quantitative data as needed, her work ranges from identifying group and institutional behavior to assessing influence and impact and developing policy and programs in response to changing social problems. She's also, in her free time, an adjunct professor of sociology at Georgetown University. And finally, Dr. Harsha Vyas is board certified in internal medicine, hematology, and medical oncology. And he is the national medical director of national co-medical director of patient advocacy for the Community Oncology Alliance. In 2017, he was named advocacy champion by the American Society of Clinical Oncology for his efforts to communicate relevant rural healthcare issues with his lawmakers. He's passionate about preserving community oncology as the way to deliver personalized, high-quality, affordable cancer care, close to of delivering cancer care close to home, and he advocates that to his lawmakers. He continues to engage state and federal lawmakers on a regular basis on various issues impacting cancer care at the community level. Dr. Vyas has been actively involved in clinical research throughout his career, and his efforts have brought emerging clinical research and trial medications to underserved and underrepresented rural patients. So I'm going to invite our panel to join us and bring up their videos. Great to see you all. And so, Sarah, before we get too far in the weeds, just for level setting, can you help us to better understand utilization management tactics like step therapy? Why do these policies even exist? What are they supposed to accomplish, and how do they work?
Yeah, so well, first of all, thank you for having me. It's really exciting to participate in your quarterly Summit. Utilization management, I view it as an umbrella term that includes step therapy, prior authorization, non-medical switching. Utilization management is basically a tactic used by health plans to try to steer patients towards a cheaper medication than the one their provider prescribed, or medication for which that health plan got a deal on by their manufacturer. So I've actually seen higher, more expensive medications preferred by health plans, and that's because that health plan got a deal on it. So it's basically a way for health plans to either save or make money. And again, they're using to steer patients towards treatments that they have deals on.
Thank you. Thanks very much for that. So Dr. Vyas, as a practicing community oncologist, I'm assuming that you've worked with a number of cancer patients who have been directed to step therapy. Can you speak about what that experience is like for patients and caregivers in your practice?
Yeah, this is, several years ago, it used to be not so prevalent, but unfortunately, this is the rule of the day. Almost every payer has some form of step therapy trying to essentially steer you towards lower cost medication, not exactly taking into account the, doctor-patient discussion or why something was actually prescribed. But basically, for lack of a better word, it's a nightmare both for the doctor and the patients. What ends up usually happening is the payer ends up saying, this is what we will pay for, but the doctor has already made a choice, and then they send you a letter saying it's not approved unless you fail this medication, and the whole thing starts. And this is true for several classes of medications, not just, not the so-called cheaper medication. Now they're starting to do this at the more expensive life-saving cancer medications too. I can give a few examples later on in the discussion. Additionally, of course, as Sarah had alluded to, the pre-authorization burden has skyrocketed. It's just gone up, and post-COVID, you would imagine after what doctors went through with the COVID pandemic, they would try to make it easy for us. That's not been the case. It's actually, I think a survey I read, pre-authorization requirements have gone up by 80%, is what I understood. And, at a bottom line, this is a cost-saving measure, which is no good both for the patient and the doctors. But we see it every day with several payers across the board, but that's the reality of it.
Yeah, and if I could tack on from the patient perspective as well, step therapy is particularly egregious for the patient population because it can take patients 2 to 3 months per treatment that they're supposed to fail from their health plan's perspective. And during that time, that's a significant delay in treatment. So I've seen patients lose organs, joints haven't been needed to replace. Cancer patients have passed away because that 2 to 3 month delay can cause severe or even irreversible health outcomes. So that's one reason I've been very fortunate to co-chair the Safe Step Ad Hoc Coalition. It is a long name, Courtney. Sorry about that. Because it has such a negative consequence for patients when they're sick and needing to get the right care in a timely manner.
Sure.
I think that you've both touched on something really important here, and that we're not only talking about cancer patients. We're talking about all patients who are suffering from a wide spectrum of medical needs. And so curative treatments or life-saving treatments or life-enhancing treatments that are being delayed sometimes to the detriment of their own treatment goals. So I mean, Sarah, you're working now for the Psoriasis Foundation, and psoriatic diseases are dreadful to live with, not just the physical symptoms of psoriasis that show on your skin, but those who are afflicted with other rheumatology aspects of the disease. And you mentioned the impact on joints and things like that. Do you have any examples of patients and caregivers in your practice who have been particularly effective at being advocates on the Hill, talking about their experiences?
Definitely. So first of all, you're right. Step therapy, some studies have said that step therapy is applied to a quarter of medical prescription drug coverage decisions. So that's 1 out of every 4 coverage decisions involve step therapy. And in the psoriatic disease community, over 99% of formularies require step therapy that's more stringent than our current clinical guidelines. So some immune-mediated autoimmune conditions are particularly affected. I have definitely seen patients and providers have a significant impact with their legislators, because I can walk into a legislator's office all day, and as charming as I think I am, they may not believe me. It's when they hear personal stories from their constituents, be that a provider, a medical doctor, a nurse, a practitioner, a patient, a caregiver, have just a very deep and profound influence. So, for example, one reason we have a bill sponsor, well, I'm sure we'll talk about the legislation later in the webinar, but one of our bill sponsors on the federal side, Senator Lisa Murkowski, is such a champion for the federal bill, the Safe Step Act, because she had an 11-year-old child in her state be required to step through or fail through 2 different treatments, lasting 6 months that he went without treatment. And by the end of that 6 months, he lost his colon and didn't even get a chance to try the treatment that, based on peer-reviewed head-to-head studies, was perfect for his particular condition and the fact that he was a pediatric patient. So he didn't even get to try the treatment that the science had backed up, lost his colon in the process. And Senator Murkowski is now such a great sponsor. This was her #1 priority in a recent committee markup. So that's huge. And that really goes to show how patients, doctors, nurses, all working together, caregivers, all working together and sharing their stories with their legislators can have a really big impact.
Thanks, Sarah. That was really powerful. And Dr. Vyas, I'm sure that you have similar experiences. And I also imagine that they're probably exacerbated given the rural setting in which you practice, in terms of access to care and access to your care, to your practice.
Yeah, these are life-saving medications where in the field I practice in, it's literally life or death. And if they don't get it on time, or something alternative has been placed instead of what we asked for, it directly leads to a crisis or a life-changing situation. I can give you an example. I had a 27-year-old Hodgkin's lymphoma patient, mother of 3, unfortunately failed frontline chemotherapy, needed bone marrow transplant. That's the next step usually when you fail your frontline treatment. The payer, transplant is a kind of a specialized field. It's called bone marrow transplantation. You have to give high-dose chemotherapy, wipe their marrow out. And there's a little bit, it's done at an academic medical center. It cannot be done in a community office. So, we constantly communicate with the specialist there, and both of us decided on a combination which would have kept her at her home, 90 miles away, close to, where she lives, as the induction chemotherapy. The older chemotherapies required you to, be in a transplant unit several days receiving it. It's no longer needed because in the advent of immunotherapy, they've been moved away. But the payer wouldn't approve it. So I tried, and then they said, no, these are in their head, what they think as approved treatment are the only ones which are approved. And then the transplant doctor tried, and they turned it down. It led to a 7-week delay. And ultimately, what's going to happen? Patient ended up in the hospital, requiring far more toxic chemotherapy. And honestly, there was absolutely no cost savings because it's far cheaper to receive the cancer treatment in the outpatient setting instead of a transplant unit where you'll actually have to pay for a hospital bed. So, this is a case. And then she is 90 miles away. 3 children are, under the care of a family member, feeling miserable. Was this absolutely needed? No. Several phone calls from our end. Patient is distressed. Another doctor's involved. I subsequently did even a phone call with this payer, and honestly, they had no answers. The standard answers were going back to the drawing board regarding our step, policy. The policy is, because they, in their perception, thought they were saving money, ended up hurting a patient. This is one of those direct examples of that.
Well, and so, I think that we've touched on 2 really important parts here, and we're going to get into, and that's why I'm so excited to have Elif here, that we're going to get into some of the conversation about the cost to the healthcare system in just a moment. But I wanted to go back to the two other aspects of cost that we're also discussing here. I mean, there's the cost to the patient and caregivers and families at home, in terms of trying additional treatments and going, having to get through them and prolong their treatment, and all of the changes to their lives and lifestyles that will have to be made to accommodate that duration of treatment. All of that has a financial cost. But Dr. Vyas, I also wanted to ask you a little bit about, the cost to your practice. I mean, you just articulated a lot of different steps and a lot of different providers who I think most of us assume are spending most of their days practicing medicine, but it sounds like there was a lot of time spent dealing with insurance companies.
Yeah, well, I'm a third generation physician. My granddad, dad, both were physicians. And my dad is one of those guys who retired when the EMR came about, when you had to type something in the computer. He's like, I am done. I use only a pen. A doctor does not touch a computer. You cannot face your back. And then now it's 1 minute with the patient and 5 minutes with documentation and dealing with, things that you think that the patient needs and explaining it to a clerk. That's what it's come down to. There are several layers of what it's led to as far as administrative burden. First of all, the number of full-time employees per an oncologist just skyrocketed. It's just ridiculous, the number of support staff we need in order to get anything done. Secondly, it's just unbelievable waste of a doctor's time. I didn't go to medical school, and residency and fellowship, 14 years of training to be explaining to a pharmacist or a clerk who's not exactly my peer on a complex topic like Hodgkin's lymphoma. That's just I shouldn't be even having that conversation. And they proudly reject with, someone, it just says there, a pharmacist or someone has looked at it and they've rejected it. It's just not fair on them too. They're just telling them, look at the policy and reject it. And they're forced to, do it. And that's, and then the unbelievable amount of, downstream effect, phone calls, the patients have to, they have to field from the patients. All of that is just financial burden, emotional burden. I'll give you another example. Just, chemotherapy chairs are extremely precious. This happens all the time where we ask for a more expensive but less frequent iron infusion, and every single payer gives a cheaper and frequent lower dose iron infusion. So what I could finish with a single sitting or 2 sittings, I have to bring the patient back 7 times, use my chemo chair 7 or 8 times, and give the same amount of iron. Whose money are they saving? Patients not saving. I'm certainly not, and I'm wasting a lot of time, which I could be using it for chemotherapy patients. And then ultimately they end up paying an infusion time. So I never understood the logic on why they would, when you have an FDA approved, more, easily deliverable iron for this. So the downstream effect of this one policy where you have to fail a cheaper IV iron for a more expensive iron is just unbelievable waste to the system. And making in a rural area, patients are driving 50, 60 miles. They've got to do that 7, 8 times instead of twice or 1 time. There's just, then you can see each time they come in, they go in, the nurse has to see them at the airport, and the burden they put on the practice, is just not needed. So there's several examples like this.
Which says nothing about, the fact that this is a patient who needs iron. Probably they're already feeling pretty crummy. I don't imagine that they feel really great after that first, second, third, or 7th infusion. I know it's supposed to make them feel better in the long run, but I don't imagine that that's a particularly pleasant experience for them either.
No, every time you come in, I have to give you pre-medication, steroid, Benadryl, 7 times, 8 times instead of once. Again, they're sitting in the chair that many times, and then they have to drive back and forth. All could have been, it just simply says must fail these older irons. That's it. There's no argument, period, full stop. I can't explain to them this is, 38-year-old mom who's already usually, having heavy menstrual bleeding, and she's probably working. She needs iron, doesn't need to take 7 times or 8 times off from her work. And each time, some of these workers in my area, the average income is anywhere between $30,000 to $35,000 a year. And if they have to take 7 times off, it's money off their pocket. They're not like having fun coming and sitting on my chair either. And then for the practice, it's just an unbelievable waste of something, a precious resource, which could be used for something else.
So, Elif, I'm going to turn to you now, because obviously there has to be a good reason that all of this is happening, right? If we're having this if these policies are having this kind of impact on patient care, patient access to care, and providers' ability to provide that care, and it has to be doing something, right? It has to be saving the health system money. That's what it's designed to do, right? So, do you want to speak a little bit about the research that you've been doing into sort of the back end of that? And, is this justified?
Very good question, Courtney. That's how we started asking that question, right? There must be an explanation. There must be cost saving to somebody in here, and if so, where it is. Don, do you want to bring the slides a little bit? So this is not a question we just started asking. We've been asking this question for quite some time. And if we look at what we've done recently, in the next slide, we started by doing a survey. We asked our participants, were they subject to step therapy for medication? If so, or were they subject to step therapy for diagnostic testing? Did they experience any unexpected out-of-pocket expenses? And not surprised, over half, 52.9% of this particular survey respondents reported they were subject to step therapy for medications, 44% to diagnostic testing, and experienced unexpected out-of-costs due to insurance companies' mandated step therapy. We can imagine that with the cost of cancer drugs and diagnostic rising 4 times more than treatment for other common health conditions. We know there's nearly 150 billion spent nationally per year for cancer care. It is necessary to determine whether step therapy reduces or adds to the cost of cancer care. So the best place for that was to go to the heart, to the core of the issue, to get claims data, to actually look at what are the claims insurance companies are receiving on their end, how they are responding to these requests, how many of them they're rejecting, how many of them they're accepting, and how much they end up paying out of pocket at the end. So we acquired, in the next slide, Don, a pretty large data set. It's a longitudinal insurance claims data that ranges from the beginning of 2018 through 2022 for 5 significant cancer patient populations: ovarian, renal cell carcinoma, metastatic castration-resistant prostate cancer, non-small cell lung carcinoma, and chronic lymphocytic leukemia. The patient cohorts and treatment profiles for these 5 cancer drugs were included in the study: Imbruvica, Tagrisso, Cabometyx, Zejula, and Xtandi. That each of them correspond to a particular cancer type. Can we go to the next slide? I just want to give a little heads up. We didn't start with 5 drugs. We actually initially narrowed down our choice to 22 drugs. And then we try to pick up the drugs that were prescribed most commonly to give us a reasonable sample size so that we can, with great confidence, say, okay, we have this data. We're going to, whatever we find is going to be statistically significant. We're going to be able to say with a certain level of confidence, yes, this is the case, that these are the numbers we're seeing. If we look at the distribution of these drug recipients, we have about 15% of them for Cabometyx, that's for kidney, 41% for Imbruvica, that's for leukemia, 26% or so for Tagrisso, for non-small cell lung cancer, Xtandi, 8% for prostate, and Zejula, about 9% for ovarian cancer. So here is the thing. We found that so that brought us about upwards of 58,000 or so cases. That's a lot. That's a lot of patients to have data on. And unfortunately, only about 5,000, a little over 5,000 of those patients were able to get the drugs that were prescribed by their doctors without any rejections. The remaining patients, over 50,000 of them, were either rejected outright and never were able to get the drug they need. That was told so by their prescriber, and the remaining little over 40% were able to get the drug after a series of rejections and appeals and whatnot. I have a couple of tables you can see in here. These are not conclusive numbers. We're just running our preliminary analysis. And you can see that this is by total number of rejections. I cut it off there for just demonstration purposes. So we have 5,400 people, 5,400 people who didn't get rejections and got the drug. Everybody else, starting from one rejection going down to dozens and dozens. There are people who were rejected 70, 80 times for the drugs they need. And that's that, you know, we've just heard Dr. Vyas what kind of a toll that takes on the patient. And in the next column, if you look at it briefly, those are the number of people who actually, if you look below zero, who were able to get the drug they needed after a series of rejections. Some of them got it after first rejection. This is the first time they were able to get the first dose of that drug after a series of rejections. Pretty high numbers. Let's go to the next slide. So we looked at rejection rates. We looked at lots of people getting rejected, but some of them are able to prescribe the drugs after a long period of time. I want to show you three bar charts here. The first chart that you see on the left does a comparison of cost, average cost per patient, in the blue column of people who were always rejected and were never able to get the step therapy drug they need. The red column represents people who were able to get the drug after a series of rejections. And the green column represents the total amount of cost for patients who actually got the drug without any rejections whatsoever. I mean, I find this mind-blowing. Like the simplest average, this is not even a crazy analysis or anything. Even look at the very basics. How much on average does using step therapy cost to the system? And we immediately see a significant difference of those who spent so much time, so much energy, losing so much health in the system, trying to get the drug and spending a lot more money versus supposedly these more expensive drugs not saving any money by withholding those expensive drugs. Insurance companies not saving any money. We can do the same comparison if you look at the middle column here. The blue bar represents the cost occurred by people who managed to get the rejections versus those who were never rejected for all drugs. And the very last one, again, looking at mean costs, those who never received the drug versus received it, just different angles of the same thing, no matter how you look at it. Even when we look at it per those drugs individually, some of them a touch more expensive, some of them a little less expensive. But the bottom line is there was no saving. We ran some analysis and we found out that on average, we can expect to see, and I think that's in line with what Sarah was mentioning, about 52 days of waiting and series of rejections and appeals after a doctor prescribed a drug for the patients to get it, 52 days. And no surprise here, if the patient is on commercial insurance, that is longer. For certain drug names, that is another 16 days on top of those 52 days. For example, Imbruvica for leukemia takes another 16 days on average to fill. that's 2 months to 3 months time range for the patients to be spending their money, their health, their well-being on drugs that do not work. I'm gonna pause here, and hopefully we can have some more conversations around these numbers, and happy to answer any questions you might have.
Thanks, Elif. I'd like to say that it's startling data, but it isn't. But I just want to go back to those bar charts for a second, because what you're talking about in terms of cost, cost to the system, we're talking about additional claims to the healthcare system. So additional claims to your insurance company for needing to go back to the doctor for another treatment. Is that right?
That is correct. So these charts represent the total number of costs patients file after they got a rejection, before hopefully those that do they get their step therapy drug prescription filled. And that's quite crazy. Yes.
So this could be anything from needing to go to the emergency room because you're dehydrated, because you've experienced nausea and vomiting over a period of days and you're not able to keep anything down, or I don't know, Dr. Vyas, I'm sure that there are other complications that you can articulate more.
Yeah, I mean, I'll give you an example. We're wrangling over growth factor shots after chemotherapy. There are clear-cut examples where you have to use it, and then there are patient-based factors and the febrile neutropenic risk being between 10 to 20%. But as the treating oncologist, when I see a 68-year-old pancreatic cancer patient who's very weak, I know how they're going to do, and we would say, we need it for what's known as primary prophylaxis, meaning I don't want the count to fall and he get into trouble. Please give it to me before that happens. And they usually argue saying, oh, this is a 10 to 20% risk. Do it as secondary prophylaxis, meaning let the count fall and then we will approve it for you. There's no time to argue with them, so we usually end up starting it. And where do they end up when the count falls? Emergency department. What are they giving them? The same IV antibiotics there, and then they're getting admitted. And neutropenic fever admission could run anywhere between $15,000 to $25,000 to the system. And they could have simply paid for a growth factor shot, which was probably 20th the cost of the whole thing. That would be a classic example of just they arguing with the doctor on a step to be followed, and then ended up paying a good bit to the hospital system. And of course, it led to a poor outcome too, more than the cost. Right. The patient's more weak, and you've essentially, we'll never be able to know how much we shortened his life, but functional status is gone. Their round 2 of chemo is not going to be the same, and all of that. So there's several examples like that. Nausea vomiting is another classic example. There are more expensive long-acting ones, but there are cheaper, shorter-acting anti-nausea medication. They clearly would say you have to fail this. Well, failing is deadly for the patient. They end up, so in a rural area, for instance, it's much worse. They're not right next to urgent care or hospital. What do? Dial 911. Depending on which ER is free, they'll drive them there. They have no idea the history of the patient. They'll just put them right next to a COVID patient. Nobody knows what's going on. Patient ends up getting a double pneumonia. It's a lot more, what could have been a simple 5-day anti-nausea medication, which we could have given, ended up becoming a double pneumonia, sepsis, ICU stay, and the worst case scenario. Or at least it ends up becoming receiving fluids and the same nausea medication being given in a emergency room, which is 10 times more expensive. Right. So these are all examples.
And Dr. Vyas, I just want to, I'm not a medical doctor, and I was looking at some of the range of cost for some of these patients who did not get their step therapy drugs. It is not rare to see a patient over the life course of the disease, after they requested their drug after their oncologist prescribed the drug, incurring costs in the millions of dollars over the course of the disease. Like I thought that would be an exception. It is not an exception. So I'm just listening to you gives me further
And Dawn,
evidence
we
that.
can take those slides down so folks can see the discussions. Thanks so much. I'm sorry,
I had a question. Oh, sorry, Dr. Vyas.
No, go ahead. No, I was just going to say that it used to be a case where, you were making an explanation for a newly approved drug, which was, not in the market too long. And, you reasonably enough, they may have not heard of a clinical trial, and you might have to do a peer-to-peer and explain, oh, this is the setting, this is what's there. This is not the case. Like you're mentioning, this is for every drug, everything. They're kind of making it so put all these speed breakers in, so the doctor and the practice gets tired enough, and then they throw their hands up and say, fine, whatever you give. That's the whole point of it. And that's how they save. They're thinking they're saving cost.
Right. Sarah, go ahead.
Yeah, thank you. My question for you, Dr. Andac-Jones, is what's the time frame for those extra costs? So it's super compelling that those extra costs are costs incurred by the insurer, but what's the time frame that those costs are incurred?
I don't want to say numbers without final numbers before confirming things, but I'm looking at different slices of patient profiles across different diseases. We're talking in some cases $8,000-$10,000 a day in additional costs for
within the plan year.
Yes.
Wow. That's
so we're trying to, so what I'm trying to do right now is to find a way to calculate costs in the most meaningful time frame. Would that be a week? Would that be a month? Because they would not be, it would be subject to a lot of fluctuations. But the next step for me is to get a slice across all drugs and across all patients, regardless of their background and stage at diagnosis and not, to come up with that cost per whatever time period that is. But in the worst case of, or best, however you want to look at it, from the insurance company's perspective, the differences between someone who got the drug versus someone who didn't get the drug, at the worst case scenario, take out all the extremes and whatnot, is over $20,000 in that rejection period. So how can you know the most basic math? Forget about discussing the, patient needs and the right thing to do and all of that. Look at this and think that this can actually save you money.
So
yeah, I think that's, sorry, go ahead, Courtney.
No, please.
Yeah, I think from a patient advocacy perspective, we want to talk about what's right for the patient, but from a policymaker perspective, so often you hear that legislators are empathetic, but don't want to raise premiums because they have constituents yelling at them about how expensive premiums are. So this kind of data has a lot of utility. From my perspective, from a policy perspective, the ideal time frame would be within a plan year, or a year if you don't know when the plan started, but within a year usually. This data has a lot of utility in terms of legislators trying to assess the costs of some of our advocacy work, which typically are exceptions bills. So on the state and federal level, they're trying to pass legislation that would enable patients and providers to skip step therapy protocols if it's medically appropriate. So hopefully you bump from that, column that said patient never received treatment. That's more expensive than the patient was initially rejected, but did eventually receive treatment. That's more expensive than the patient that just got the treatment right away. Hopefully we can start to bring those columns closer together with this kind of legislation. And again, this data that shows that patients that get the treatment right away are cheaper for the plans in the long run is not only great to share with plans, as Dr. Vyas, you mentioned earlier, we should send this email here, but also great to share with legislators on both the state and federal level that are considering policies to streamline step therapy for patients and providers.
And like Dr. Jones mentioned, there's a particular reason why commercial insurances have a bigger problem with this, because in general, Medicare tends to listen to the doctor more. I'm not saying that they're perfect, but they are certainly have less of this, crazy step therapy situation going on there. And I could tell you, there has been an exponential growth of the so-called Medicare Advantage plans. I like to call it Medicare Disadvantage plans, because they are as they do more and more egregious stuff like that, I don't think they're realizing that they're actually going up on the cost. And like you said, all the time there is this boogeyman, I'm going to go up on the premium, and your seniors in your district are going to, come after you. You don't need to. Even from a simple cost standpoint, you'd be saving. And you could just look at your not so cool cousin, Medicare. They are actually not having the same situation.
And I mean, just to throw a little bit of data out there, I'm looking at comparisons of commercial versus Medicare, Medicaid recipients in this data set. What I'm seeing, without adjusting and controlling for anything yet, there is at least $8,000 less cost on Medicare patients on average than commercial, which for patients who are on step therapy. That like as simple as that. It's
and there you go. I mean, that's just unbelievable. Yeah.
I can definitely see that reflected in the policy realm, and I see a lot of my colleagues are in the participant list. So I'm just gonna gloves off, dive into some wonky talk. But patient advocacy communities have done amazing work engaging Medicare, Medicaid, the ACA plans. But the commercial market is really where we just haven't tackled as much, as based on my perspective. And that's one thing I really like about the Safe Step Act, which is the federal step therapy reform law. It's based off of state-based laws that have passed in 37 states now. They've done a really amazing job on the state level. The state laws apply to small group and individual marketplace plans, but the big gap are those employer-based commercial plans. The Safe Step Act applies to those largest commercial plans, which are those employer-based commercial plans, and it would try to set up a step therapy exceptions process very similar to what Medicare already has. So it's great to see that your data is showing the difference between when you have an exceptions process, like in Medicare, versus when you don't, like in a lot of these large commercial plans that are typically employer run. Another comment I'll make, Dr. Vyas, you mentioned, you see the most egregious step therapy protocols in commercial markets. One thing that has been just tip of everyone's tongue this year on Capitol Hill has been about pharmacy benefit managers. And the Senate has included the Safe Step Act as part of their pharmacy benefit manager reform package, because PBMs, pharmacy benefit managers, are often contracted with by these large commercial plans to handle formulary design. But the problem with them is that these plans, these PBMs, I don't think they're being fed back the data on what's going on the medical benefit side. So they deny your treatments that you're prescribing, but then they're not getting the information back to them that that patient had to be hospitalized. They went to the emergency room. They went to the doctor 7 additional times, as opposed to that one drug injection that they could have just gotten and been done with. And I think that's part of the reason why you see this really mind-numbing disparity in costs in terms of why is it so much more expensive? If it's so much more expensive to apply step therapy, why are these insurance companies doing it when they're supposed to be, business gurus, the smartest of the smartest? And I think it's because
I'll tell you, there's
medical
one
care has
simple
been.
there's one simple explanation on the PBM side. 3 big boys, Optum, Express Scripts, and CVS Caremark, control over 80% of the prescription market. So they have almost monopoly. Everybody knows this racket. And, there's several bills now introduced. In addition to not knowing, let me just say, they don't care. They don't have to. It's vertically integrated. Optum's, UHC, all of these guys, they are like massive multi-billion-dollar corporations. Don't even get me started on the PBMs. We deal with them. I have additional 3 FTEs just for that. But, they may know about it, but they don't have to deal with it because they're just so massive and they control such a large part of the prescription market. Where are you going to go? I mean, when you control 85% of the prescription market with 3 companies, and, UHC's market cap is $400 billion. So this is a situation where, I'm sorry to say this, they're too big to fail at this point. And unless you have data like that, feeding them back saying, guys, we don't know the real reason. Maybe maybe you don't know. but you're wasting doctor's time, patient's time, and you're wasting your own money. They have to be fed that information loud and clear. There is a treatment TACT Act coming through the House, Timely Access to Clinical Treatment Act. It's got bipartisan support. We went on an advocacy trip. It's going to make its way, and it requires insurers to approve treatments within 72 hours, which are FDA approved and doctor prescribed. There's several like this. PBM reform bills are coming up, and it's some of these things are common sense, and this data set being presented, I mean, it's just like flies right on your face for them to see, look, this is mutually beneficial for, yeah, you're a for-profit corporation. We expect you wanting to make money. That's all fine. But you get to save money and help patients and not drive doctors mad. So this is a win-win for everyone.
Well, on that note, I'm going to invite our participants to please ask questions in the Q&A. I think the one question that's already there was answered emphatically by our panel, that I think we have a lot of really grand designs for this research, including federal and state advocacy and delivering the message directly to those insurers who are making these decisions. But Sarah, my feed cut out just as you were about to make a definitive point about how medicine has been, and then it cut out. So in your comments, I didn't know if you had had a final point that you wanted to make about how PBMs were dividing medicine.
Yeah, I was just saying they're only focused on the prescription drug benefit side, and they're not looking at the medical consequences. So it's great to see bills like the Safe Step Act be included in the Senate PBM reform. It's unfortunate so far on the House side, the Safe Step Act has not yet been included. The Education and Workforce Committee, which has jurisdiction over the Safe Step Act, marked up their PBM reform package. They did not include the Safe Step Act. They did talk about it a little bit, so that was great to see. As the advocacy community continues to push for passage of a final PBM reform bill, like Dr. Vyas said, I think we all would like to see making sure that the Safe Step Act is included in the version that passes the Senate, and that the Ed and Workforce Committee moves on a version of the Safe Step Act soon, so that it can be in the final House version too, and easily conference is really important. So that's the point I was making.
Well, and I want, on that note, Dr. Vyas, I don't think that we have slides or additional information on the legislation that you mentioned, but we do have resources on the Safe Step Act available in the resources tab at the bottom of your screen. I also would like to thank the panel for reminding me that I was referring to my CSE colleague, Dr. Andac-Jones, in the familiar, because we work together on a daily basis, but I appreciate you acknowledging her contributions to science as well. I'd like to remind everyone again that you're welcome to submit any questions that you have in the Q&A. But I will also, I'm going to turn it over to our panel for final thoughts as we're looking for questions in the Q&A. So Dr. Vyas?
I think this is a great beginning with all of these data sets. Once it's curated, I think this is, not counterintuitive at all for me. This is what I would have expected to see. And if this is actually can be placed in front of powers to be, this is a kind of a mutually beneficial situation. Like I said, the practicing medicine, there is the most pleasurable aspect of it is being with the patient and understanding the problem and talking to them. And it's almost like a, conversation you're having several times of the day with several different people. And that's what doctors get into the profession for. And that's what drives you to do things. But if you're constantly spending all the time in the back of your head, God, I'm going to prescribe this medication. God knows how this is going to turn out to be. And it just sucks the joy out of what you have to do. So there is a psychological toll it takes on the medical community, and it's a horrible situation for the patient. Just for that one reason, fixing this will have a huge impact, and also from cost to the exchequer, it's just like a win-win all around. So I just sincerely hope that they see the obvious and just do the right thing.
Thanks, Dr. Andac-Jones.
It's been a true pleasure, very eye-opening for me. I think this is one of those situations where research can get as impactful as one can hope for. I'm hoping at CSC and with colleagues like you all around working on this together so that we can open up these findings to everybody's use as soon as possible.
And Sarah, I'm going to give you the last word.
Thanks. Yeah, I'll echo Dr. Andac-Jones. I think there have been really pivotal research studies showing step therapy utilization management causes $1 billion in annual costs because of the money providers spend. Patients are spending out of pocket and payers are spending to implement it. What's new about your study is that it shows the cost to insurers, or at least the costs of patients' additional medical needs. So that's really interesting. I can't wait for it to come out. I think it will have a lot of utility with decision makers, both on the federal and the state level. And we have an unprecedented opportunity in front of us on the federal level to try to address step therapy for those larger commercial plans that have been heretofore pretty much unaddressed through the pharmacy benefit manager package. So really appreciate the work that CSC has been doing, but then also for all the advocates listening to the call, just really want to keep encouraging you to hit the drumbeat, keep getting more co-sponsors for the Safe Step Act, and then also encouraging leadership and committees to support and pass the bill. And hopefully we can not only bring those bars costs closer together so that it matches the lower costs of patients getting the treatment they need in a timely manner, but per Dr. Vyas' comments, actually helping patients hit remission and be happy, functioning individuals in society. So congratulations on a really great study, and appreciate the opportunity to discuss it.
Well, thank you all so much for your time. This has been a really exciting opportunity to discuss this research in its early stages. And I know that we have to interrogate those data, and we will be putting out a study. But I think that these are some promising results that point us in a direction of really having some compelling advocacy steps to take. And so, as Sarah noted, a lot of you all on the phone are advocates in this space already. So when you receive the link from this webinar, I encourage you to share it with your colleagues, with policymakers, people with whom you have connections. And let's keep this drumbeat going, as Sarah said. So with that, Dawn, I think that we're ready for our last slide, our last Q&A, or I'm sorry, our last polling question. That's the word I was looking for. So based on this discussion, what actions are you likely to take? Now, I guess if a lot of you are already DC focused, or sort of in the realm, this might be old hat to you, but I do see a lot of folks indicating that they're willing to write their members of Congress, contact CSC and learn more. Yes, we will absolutely be sharing the information, and please feel free to reach out. And we also encourage you to weigh in on what additional topics you'd like to see covered in additional roundtable discussions. So with that, I think I'm going to end the polling question. Once again, thank you to our panel. Thank you to our sponsors. Thank you for this great discussion, and we look forward to hearing from all of you. Thanks so much, everyone.
Thank you. See you all.
Thank you.